All right. Welcome, everyone, to another installment of the podcast series of the North American Spine Society, where we highlight articles from the SpineLine publication. I'm Dr. Alex Michael, and I'll have the pleasure of moderating this latest edition. I'm a neurosurgeon at Mercy Clinic in St. Louis, Missouri, and also have the honor of chairing our Public Affairs Committee with the North American Spine Society. Today, joining me is Dr. Jason Friedrich to discuss his paper, Managing the Gray Areas of Degenerative Cervical Stenosis, Mild Myelopathy, and Asymptomatic Cord Compression. Dr. Friedrich is an associate professor in the Department of PM&R at the University of Colorado. He's the medical director of the University of Colorado Hospital Spine Center, and also the program director of the Pain Medicine Fellowship. Dr. Friedrich, thank you so much for joining us.
Thank you. It's my pleasure to be here.
All right. So the primary goal of surgery for patients with cervical spondylotic myelopathy, we know, is to prevent the progression of neurologic dysfunction, disability. However, treatment plans are more variable for patients with cord compression who are really asymptomatic or non-myelopathic. So in his article, Dr. Friedrich reviews the natural progression of cervical stenosis and cervical spondylotic myelopathy. He'll identify clinical and radiographic prognostic factors, all to help provide recommendations for management. So before we really start talking about cervical stenosis and myelopathy, I think we just needed to define what this means for the listeners. And the definition the paper uses is a radiographic one, defined as cervical canal diameter of less than 12 millimeters. Now, can you tell, is that an MRI definition? Is that based off of CT scans or X-rays historically?
Yeah, that's a good question. So in general, obviously cervical stenosis implies some narrowing of the spinal canal, and we know that the canal does naturally narrow, further as we age to some degree. And so when considering a numeric definition for cervical stenosis, the less than 12 millimeter diameter is a reasonable number to use. Our paper pulled that definition from a study of donor skeleton specimens, but MRI studies of stenosis often use a similar definition, plus or minus a millimeter. So I think it's important to note that, the canal diameter measurement alone tells us little about the degree of cord compression or the degree of myelopathy risk, which ends up being more important clinically. And now to your second question, myelopathy is defined as spinal cord pathology. And for the cervical spine, this implies some combination of reduced manual dexterity, balance impairment, hyperreflexia, and in some more severe cases, you would get muscle weakness, numbness, bladder dysfunction, and spasticity. So cervical spondylotic myelopathy or spinal cord pathology due to degenerative changes is the most common type of cervical myelopathy and is really the focus of our paper here. And since we're talking about definitions, it's important to note that many adults who will meet criteria for cervical stenosis and even may have spinal cord compression may not have signs of myelopathy. And so in the paper, we discuss, one study that showed about a third of adults will have spinal cord compression by the age of 50, and about 2/3 will have evidence of cord compression by age 80, yet in that sample of about 250 subjects, only 1% or so had neurologic findings of myelopathy.
Right. And I think that's the gray area that you guys refer to in the paper, that the patients with cervical spinal stenosis without myelopathy, or those with only just mild symptoms. So those are the trickiest ones for us to come up with the surgical plan for. To me, this is probably one of the most important points and really the basis for the whole paper, that radiographic cord compression alone doesn't predict those neurological findings. So what we wanted to identify is at what point does the perioperative risk actually outweigh the risk of not having surgery? And that's why elucidating the natural history of asymptomatic cervical stenosis is so important.
Yeah, absolutely. So we do know that the progression of cervical spondylotic myelopathy over time is variable, and it may manifest as a slow stepwise decline, or there may be long periods of quiescence. However, we also know that myelopathy can progress to cause permanent functional impairment and is actually the leading cause of spinal cord injury in adults. So therefore, all of these cases do need to be monitored.
And you guys touch on some of the most common etiologies of cervical stenosis: congenital, traumatic, and the much more commonly one we encounter, degenerative. And those degenerative changes, just briefly, that are touched upon, start at the intervertebral disc. And because of that degeneration, it puts more stress on the uncovertebral joints, causing hypertrophy. Same thing with the facet joints, ligamentum hypertrophy, and then potentially even spondylolisthesis. And then those patients with congenitally narrow canals are more predisposed to spinal cord compression from these degenerative factors. And then both of those may predispose patients to injury in the setting of trauma. Could you maybe briefly touch on the pathophysiology of myelopathy because of degenerative stenosis?
Certainly. And, while this is a gross oversimplification, one can consider, consistent pressure on the cervical spinal cord leading to ischemia or loss of adequate blood flow to neurons and other cells that support normal nerve function. This can lead to local swelling and cell death. And so while the spinal cord and its nerve cells can adapt to some compression and potentially not generate any symptoms or at least any persistent symptoms, there's often going to be a threshold where adaptation is no longer possible and persistent symptoms and signs of myelopathy then develop.
So, and coming up with the summary for this paper, you guys looked at a lot of different radiographic factors used to describe cervical stenosis and myelopathy. Did you find any specific ones that correlated better to worse functional outcomes?
Yes, and I think this is one of the key points of the paper. I'd say that your most useful radiological correlates of developing progressive or worsening myelopathy or worse functional outcomes would include cord signal change on MRI, the spinal cord compression ratio, which is the sagittal cord diameter divided by the transverse diameter, and then lastly, the cross-sectional area of the cord at the level of maximal compression. So AP diameter of the spinal canal and the Torg-Pavlov ratio on radiographs really does not predict myelopathy progression well. But obviously, having a large diameter canal does reduce the risk of ever developing myelopathy.
Yeah, I'm just trying to think of those patients that we see that can't get an MRI, so we can never actually definitively see if there's core signal change. Maybe what would be the best predictor for them? I would assume it would be that AP diameter to the transverse diameter, that compression ratio you guys talked about, like a CT myelogram.
Yes. Yeah, I would agree with that too. Yeah, you can still, even with a CT myelogram, even though you can't assess for cord signal change, you certainly could get a reasonable estimate of the spinal cord compression ratio, or even the cross-sectional area of the cord at the site of maximal compression to get a reasonable sense. But certainly, your clinical exam, as always, it ends up being most important.
And that brings me up to the next point too, talking about some of the functional scales that we use to actually grade myelopathy. Modified JOA, the NURIC scale. Those are probably the most common that I use in practice, unless they have rheumatoid arthritis. Then using the NURIC, using Ranawat grading scale. Can you tell the audience what grading mild myelopathy would be based off of these scales? Mm-hmm. And then do we know anything about progression of mild myelopathy based off of that initial grading?
Mm-hmm. Yeah, I'd have to say in doing this review, the vast majority of papers do use the JOA or the modified JOA for grading myelopathy and trying to predict progression. And so that scale includes 4 domains, including upper limb motor or dexterity dysfunction, lower limb motor or ambulation dysfunction, sensory loss or pain, and sphincter dysfunction, especially with respect to bladder control. So the modified JOA scores on a 0 to 18 scale, with mild myelopathy defined as greater than or equal to 15, and then moderate to severe is less than 15. And so looking at, using that scale as kind of your baseline, rates of progression from mild myelopathy advancing to moderate or severe, requiring surgical decompression, at least after initial conservative management period, range from anywhere from 20 to about 36%. And like I stated before, the progression may be a slow stepwise decline rather than just continuously progressive. In many cases, patients with mild myelopathy may actually be stable for many years. One meta-analysis went out 3 years and found that about 70% of patients with mild myelopathy, as graded by the modified JOA scale, who were treated non-operatively, showed no decline and even maintained some clinical gains in ADL assessments and gait speed with conservative treatment. And so ultimately we concluded that for patients with mild myelopathy, initial conservative management with close follow-up for the first 3 to 5 years is certainly reasonable, after discussion of the roughly 25% chance of some progression during that time.
And just to clarify too, so the patients that had what we called cord compression and asymptomatic, did they all meet that criteria of severe cervical spinal stenosis of less than 12 millimeters, that number that we had talked about earlier? And then could you maybe then share what you found in the literature for the history of stenosis in those patients that are not myelopathic yet?
Yeah. So all patients with cervical cord compression did meet criteria for cervical stenosis using a less than 12 millimeter canal diameter definition. In the asymptomatic patients with degenerative cervical canal stenosis and cord compression, and when I say asymptomatic, I mean folks that don't have clinical evidence of myelopathy. They may have some neck pain. And in these folks with cord compression, either with or without cord signal change, clinical myelopathy developed in 8 to 35% at 1 year follow-up, and in about 23% at 4 year follow-up. So in patients without clinical myelopathy, but do have this canal, significant canal stenosis, the presence of radiculopathy actually does increase the risk of becoming myelopathic within 12 months. And so that can be certainly a risk factor that can be used. And then similarly, asymptomatic patients that have a T2 hyperintensity within the cord are also at an increased risk of developing clinical myelopathy, especially after a 12-month period of time. So the other findings that we found that could potentially independently predict the risk of becoming myelopathic, again, in that patient that at baseline has some stenosis and some cord compression, but no myelopathy, would include folks that are somewhat hypermobile, have increased cervical range of motion or some segmental hypermobility, or that have at least 60% canal narrowing, or that have ossification of the posterior longitudinal ligament, especially when the ossification is somewhat laterally deviated.
I think, honestly, this has already changed my thought process in counseling patients in practice already. Just knowing that seeing a lot of patients with radiculopathy and maybe keeping a closer eye on them, knowing that they could potentially progress if they have high-grade stenosis, but not myelopathy. So I think that point needs to be driven home even better. The other thing you mentioned, I think, is a great point too, just putting in the context of the patient. If the patients are younger, they're going to be more active and functional and potentially progress more than our older, more sedentary patients. So that's probably something to then always keep in the context of the patient too. The one thing I was really interested in was the cord signal change. We know that is independent risk for progression. And we know if we see cord signal change, I already counsel people that those are the ones that they're mild with cord signal change. Those are the ones that you can most help. It's once they become more moderate or severe with cord signal change that you feel like you don't have as big of an impact with surgery. Did any of the studies you looked at for asymptomatic patients look at cord signal change versus without, or just take that piece and remove it entirely? Or do you think that these asymptomatic groupings, are they kind of polluted with patients with cord signal change too, that may have kind of weighted those patients down to actually progress in this group?
Mm-hmm. Yeah, that's a good question, and I'd like to just echo what you said there. And I'm in the non-operative realm, and I follow a lot of people with cord compression, a lot of people with early myelopathy. But it is true, even the folks that have no clinical myelopathy, but if they do have some cord signal change, I generally want them to have a relationship with a surgeon, even though I've seen them and followed them as well, just because I think once they do develop any symptom, I want them to kind of already be prepared to move forward. But with respect to your question, about kind of subgrouping out. What happens to the non-myelopathic patient that has cord compression or severe stenosis, but no cord signal change? I got to say, it's not really well answered in the available studies. What I can tell you is that the degree of spinal cord compression is not a good predictor of symptoms of myelopathy by itself. And it really shouldn't be used as a surrogate for a good clinical neurologic history and exam when making surgical decisions. So retrospective studies do tell us that, having increased cord signal change increases the odds of you becoming, or excuse me, I shouldn't say that, the odds of you having clinical findings of myelopathy by about tenfold. And then the other finding that shows up is somebody with segmental instability, like a spondylolisthesis, at the side of the most severe cord compression will increase the risk of having symptoms of myelopathy by about sixfold. So in other words, for patients without any of these features, so no segmental hypermobility, no increased cord signal change, but with severe cord compression, there's really little research that helps us predict who's going to go on to become symptomatic. And there's little research support for or against surgery in these non-myelopathic cases. So of course, it becomes really important that these patients are monitored, clinically over time with a good neurologic exam, and kind of multiple points of shared decision making about what to do in the future.
And that is just another ploy for multimodality imaging, making sure there's no movement on flexion extension to go along with the MRI, because that just only tells one picture. And I tell patients that every time I see them. The MRIs are when they're lying flat. It doesn't tell us what they do in real life. It doesn't tell us what gravity does. It doesn't give us an indication of how much mobility is at that level with dynamic flexion extension. So I think that's an important point to drive home. I think that's a fantastic overview of the paper with all the highlights. I think it would be great if you could maybe just summarize once again with all the data we've talked about, just the take-home messages from the paper. And you guys provided a great review of the natural history of cervical stenosis and myelopathy, along with some of those prognostic factors that you think should be considered for the management. Could you give us maybe a conclusion for what you would give advice for management of mild, moderate, and severe myelopathy?
Sure. Yeah. So I would say, kind of in summary of the paper, so the management really depends on clinical presentation and correlation with some of these radiological findings. And so in general, I would recommend using some sort of a grading scale. And so the modified JOA would be the one that would fit best with the literature that's out there for the majority of your patients. So folks that are graded to be moderate to severe spondylotic myelopathy, should typically be managed surgically. These folks have little functional reserve, and really any progression of symptoms are potentially irreversible. So now for patients with mild myelopathy or non-myelopathic cord compression, conservative management with long-term observation is certainly reasonable. And then these specific clinical and radiologic findings discussed in the article can help you predict risk of neurologic deterioration a little bit further and aid in some of the clinical decision making and counseling.
That's perfect. Well, I know there's a lot of data for review, so I just want to encourage all our listeners to pick up the latest edition of SpineLine put out by the North American Spine Society. Read the paper in further detail. I think it's just incredibly high yield information for all spine healthcare professionals. And Dr. Friedrich, thanks again for your time putting this together. Thanks for being with us today and going over the paper. I think that's all it. Any last words from you, Dr. Friedrich?
No, just thanks so much for having me. I think this has been fun, and again, I'd like to just give a shout out to SpineLine, because I think it really does provide a forum for trying to provide really clinically practical and useful information, and that's kind of why I like being part of it.